The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the February 2020 edition of the Pre-Hospital Care Research Forum Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. And we believe it's the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. And here with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Remley Crow, and I am joined by Dave Page and Dr. Tony Fernandez. And we are also really excited today to have some special guests with us who authored this paper, Dr. Casey Patrick and Dr. Rob Dickson, the EMS medical directors at Montgomery County Hospital District in the great state of Texas. The name of the article we're going to be reviewing is The Feasibility, Effectiveness, and Safety of Prehospital Intravenous Bolus Dose Nitroglycerin in Patients with Acute Pulmonary Edema. And this is hot off the press, literally days ago, out of Pre-Hospital Emergency Care. So this review is paired with an article that will be written by columnist Dr. Tony Fernandez in EMS World called Journal Watch. And we encourage all of the listeners to check out this article at emsworld.com under the category of education and training. And so thank you all for joining us today. But before we begin, I want to remind the listeners, you can always use the chat feature on your screen to type in questions and comments. And we'll be bringing those in live as we go. So anytime you have a question or comment, go ahead and put it in that chat box. And I want to take a second just to thank our authors. So thank you, Dr. Dickson and Dr. Patrick, for joining us today.
Great. Thanks for having us.
Thanks for having us, Remley.
Awesome. I'm going to remind everyone of the objective of the study. And so that was to assess the feasibility, safety, and effectiveness of pre-hospital IV bolus nitroglycerin for decompensated CHF patients with acute pulmonary edema. I thought it would be interesting if we could just start off with asking the authors a little bit about the background on this and what made you all decide to work on this particular project.
That's a great place to start, and really it extended for me from residency. You know, this subset of patients, the acute pulmonary edema, decompensated CHF patient, is one we all recognize, and it falls outside of the classic CHF exacerbation patient, or at least is definitely a, more severe version of that hyperdynamic sympathetic surge patient. When learning this in the textbook, though, oftentimes we hear about, Lasix or furosemide, and when I trained, morphine was in the mix. And one of my most beloved mentors was an early adopter of early afterload, early preload reduction with nitrates. So following that through after completion of residency and seeing some of the work from Wayne State and Levy's group, the preliminary work with this in the States in the ED ICU settings, the data was really compelling that this decreases intubation rate, decreases length of stay, decreases ICU admission in these patients if we can, volume shift them quickly. So from our standpoint, my standpoint, it was really something that I'd started to use in my clinical practice that I felt like translated directly to the pre-hospital setting, in that the quicker that we can shift these patients, the better their outcomes are going to be, or at least that's what we presume. Right. That was the foundation, I guess, of the building blocks for the study and for trying to get this data out there.
That makes a lot of sense. And this is something that we've been doing in the hospital for a while. So it was interesting to see how you all brought this to the pre-hospital setting. And for those who aren't familiar with the great state of Texas and Montgomery County Hospital District, could you just tell us a little bit about the service where this was implemented?
Sure. So we're located just north of Houston proper. It's a vast area, about 1,100 square miles. We have probably around 250 ALS providers on 30-odd trucks, split 12 and 24s at any given time here in the county. We're supported by another 1,200 first responders among 13 different fire departments. So pretty big service. The population up here is about $750,000 now. So it's a mix suburban and rural, with about 65,000 calls for service a year.
Right, and I think that's important too, especially for this kind of a project where we're assessing feasibility, making sure that you're going to have enough patient volume in order to be able to test this in a reasonable amount of time. So I think that's important background information. And let's go ahead and dive into the protocol before we look at analysis and things like that. So Jen, if you could take us over to table 1, that's the first slide. Could you walk us through a little bit about what the pre-hospital protocol looked like?
So this is the final version. We really poured over this for several months. This was the first U.S. Version that we knew of trying to push the higher doses. That's where really, even in the hospital setting now, in my practice and talking to others, I think everybody knows that nitrates are standard in these patients, but pushing the doses up high enough to dilate the arterial side along with the venous side, it really requires higher doses. And whether that's a high dose drip or a high dose bolus, that classic 20 Max drip is that's a BB gun and an elephant.
Yeah, when doctors really do the math on that, and they realize it's a fraction of what's required.
So we use the Wayne State Group's papers really as a guideline and a foundation. And in their studies, they pushed 2 milligram doses with really unlimited repeats. As the EMS medical directors, this was really my pet project. I didn't want to have people passing out and rolling into the EDs with pressures of 60 over palp. So we cut that in half and limited it to 2 doses and felt like that was being adequately safe. So in this protocol, we required both hypertension and respiratory distress. That was an effort to weed out those chronic hypertensive volume overload patients who've been off their Lasix for 2 weeks and called us with some shortness of breath and were speaking normally with a pressure of 185. That's not the group that we were targeting. We were targeting the real hyperdynamic, sympathetic crashing, if you will, tachycardic, hypertensive, hypoxic, tripoding, diaphoretic patients. So when we taught this to the paramedics, we taught it as moderate to severe respiratory distress plus systolic greater than 160. And again, that's the systolic pressure that Levy's group used in their studies. And to make that simpler to folks, we really described it as if you're going to put them on non-invasive positive pressure and they're markedly hypertensive, then consider IV nitrates. Again, at a 1 milligram dose, slow push, and an option to repeat in 5 minutes if the systolic remains greater than 160. We still allowed for sublingual use and prior to IV or IO access. Encouraged 12 lead acquisition in these patients to evaluate for ischemia, and then talk the physical exam findings that that I just mentioned. Rouse, tripoding, diaphoresis, hyperdynamic, tachycardic, hypertensive.
Right. And now this sounds like an intensive protocol, and y'all talked about how this is the final protocol. So as you were building this, did you all get the paramedics involved in the development of the protocol?
Yeah, absolutely. Really, we tossed around the idea of, and I've talked to some other services out there who are in the early stages of doing this, and there are a lot of folks that are pro drip, pro high dose drip. That was one idea that we tossed around with a lot of paramedic input, as far as we really wanted to look for the least invasive, the least difficult way to implement this. It was really why we fell on the bolus route, because easy to dose, easy to administer. At a 100 mic per mil concentration in the big glass bottle, it allows you to dose that at 10 mils, which is fairly simple to draw up. There's no tubing, there's no drip calculation or drip sets. If you're lucky enough to have pumps out there, there's no pump settings. And looking at Levy's data, a large proportion of their patients, just like a large proportion of ours, only required a single bolus. So from the standpoint of ease of use, if you're only going to need one single IV bolus, why go down the pathway of setting up a drip? Now, if you're in a long transport time situation, which thankfully we're not here, we're in that half an hour range, plus or minus, the argument definitely could be made for maintaining a drip, but we just felt like from a simplicity standpoint, it was the best route to go.
Right, and I think that came from the bottom up. I mean, we listened to the medics for their input on whether or not in these sick patients, it's going to be a high stress situation. What's the easiest that's going to provide the maximum amount of therapy with the least amount of risk for the patients. And we both felt that, as the majority of our medics did, that asking them to set up a drip and calculate a drip, that's not in the bag, you have to go back to the truck to get it, was an undue burden. So that's probably a very common question. One of the most common I get is, why did you guys do it with the push dose instead of just a high dose drip? And those are the reasons.
I think that's great, getting the support from the bottom up, like you said, of those who have to enact this on the front line, and especially when patient safety concerns can be at play. And speaking of that, I think it can't be underestimated how much work went into deploying this kind of a protocol. So it might be helpful for our audience if you talk a little bit about what kinds of training and what did you have to do before you could just roll this out? Because it's not like you come up with it and then you just roll it out the next day.
No, exactly right, Remy.
Yeah, I mean, I've been with the EMS service here now for almost 4 years, and was brought on primarily with the goal of providing additional educational opportunities for the paramedics. That was my initial job description, really. So I set out around the office and out in the field and in the hallways, what do you want to know more about? And the number one, before this protocol was ever dreamed up, before this paper was ever started, the number one clinical question that I was asked was, how do you differentiate between COPD and CHF? So that was sort of the genesis of all this, was thinking about how to better teach COPD versus CHF, which led into treatment of CHF in the pre-hospital setting, and how to differentiate between different variations of CHF, from chronic volume overload to cardiogenic shock to our decompensated acute pulmonary edema group here. That really was where the teaching started, was how to target those three groups and to take them as three separate entities, as opposed to a blanket CHF exacerbation description, which really is oftentimes isn't very helpful. Then from there, it was specific exam findings, listening for rows, looking for edema, looking for the acuteness, really, because this is not a chronic volume overload patient we're targeting. It's 2-3 hours of acute shortness of breath that really came out of nowhere in that sympathetic sort of downward spiral.
Right, and as far as our process, Remley, that was kind of the guts of what all the didactics was. But the process itself, we're well supported here. We have a very supportive board and to our educational process. So every quarter we have, Dr. Patrick and I have time with the medics. And so we have mandatory CE that's for all of our providers. And so we had them in for essentially a 2-hour session that was didactics, kind of a slide deck that you guys are using here with some of these concepts of trying to sort through the flavors of CHF and targeting this therapy to just the subset that's an acute hypertensive pulmonary edema.
And admittedly, we got some cross-eyed blank stares with the introduction of a milligram nitroglycerin bolus. Like, you mean 1,000 micrograms, 1 milligram? We got those questions, and really we relied on the prior hospital research, again from Wayne State, some of the other Israeli and French studies that were out there that are a couple decades old, and we showed the medic, those results in stylized graphic forms to try to make the numbers pop. I'm sure it's not as good as the ones that you would have put together, but we tried to show them that this benefits the patient in that they don't stay in the hospital as long. They don't go to the intensive care unit as often. They may not even get intubated as often. So when you take it to a real clinical patient-oriented outcome as opposed to a blood pressure reduction or some BNP value or something that the medics can't grasp, and even, you know, the emergency physicians can't grasp. If you're telling the medics that, hey, these don't go to the ICU if you drop their afterload, you drop their preload, that's easier for them to hang on to. So we really relied on some of that, you know, foundational ED ICU literature as well to try to, you know, have a good sell job, because we wanted them to be on board with this and to see it as an opportunity to really help patients in the end. And if you do that, we found with our service here that the medics really will latch on.
And that's awesome. I think explaining that why behind you do something is always so important. And I know Tony's anxious to get to the methods, but I wanted to highlight something that was described in this paper that I found quite innovative. So not only did you all do the didactic classroom portion of this, but you all disseminated some of this knowledge to the folks who are going to be enacting it through podcasts. And could you talk a little bit about your decision to use a podcast to help disseminate this information, and how was your experience with that?
I would say that's a result of probably trial and error and a year worth of failure. As I said before, I was brought on for adjunct education, and I did the traditional PowerPoint slide deck, you know, 60, 80 slides, couple hours, schedule a month in advance, non-mandatory extra educational settings. And in January, we had 10 people. In February, we had 12. In March, we had 14. And it never really climbed much above 20. And as you heard Rob say before, we've got 250 plus paramedics. And by October, putting, you know, 10, 15, 20 hours into these, you know, nice PowerPoint, I thought they were great PowerPoint lectures, and having less than 10% of our service show up, I started to get frustrated with myself, with, you know, with the goal. Why is no one coming? And then I don't know why it took me listening to an MRAP or an MCRIT or some podcast on the way home one day and realized that I don't go to the hospital on my day off and listen to live lectures. I don't do that anymore. I wouldn't do that. Why am I expecting my medics to do that? So around the same time as we floated the bolus IV nitrate study idea, I came with crazy idea number 2 in the office, and that's that we need to release this via podcast as opposed to asking people to come in on their day off for free to sit in traditional old school seats. And we really found that the medics enjoyed it. They were overwhelmingly positive with their, you know, with having it as an option for, you know, adjunct learning. It's not part of, we still have mandatory continuing education options for them, but it really has been a nice adjunct again to that. So they have another way to listen and to learn, and they can do it on their own time. You know, it's not anchored to a computer. It's not anchored to a seat. It's in the car, on the go, commute, gym, jog, you know, easily consumable and easily digestible.
That's awesome. So Tony and I just spent the last few days at the FISDAP Research Summit, which brings EMS educators together. And one of the conversations that kept coming up is these different methods of learning. And, you know, we're talking about things like flipped classroom, and we're talking about different ways of reaching different audiences. So I think that it's unique and innovative that you all included this. And in the peer-reviewed manuscript, you discussed how you use different ways of reaching the audience. So thanks for highlighting that with us.
I've got to say, it's actually really refreshing to hear you. I think you even got Remley with a little twang of Texas accent going on. So you're a Texan now, but it is refreshing to hear you try to reach your medics and support the medics and involve the medics in the research. So congratulations.
And that's a good thing, Dave, that there were a few EMS professionals on this manuscript, and that's really awesome that you're able to get not only the buy-in, but support and actively engaging your EMS professionals in the research.
Yeah, I have to quick plug my cardiac coordinator, Brad Ward, was invaluable in chasing down some of the hospital data that we had to chase with organizing our chart collection, with chart review, and we had multiple votes on is this COPD, is this acute pulmonary edema, and Brad was invaluable. Jordan Anderson is our clinical chief. He was invaluable from the standpoint of deciding where to get the nitroglycerin from, how to stock it on the ambulance, all the logistics, and the mechanics of stocking it on the trucks and taking care of it, showing up, making it happen. Yeah, so we really had excellent medic support and buy-in from our Department of Clinical Services here. So we really could not have done this. We would not be talking to you if it weren't for those two folks, for sure.
That's awesome. All right, well, Dr. Fernandez, would you like to take us through just a little bit of the methods before we move into the really exciting results?
I absolutely would. And again, I want to thank the authors for joining us today. I think this was a really interesting study, and I'm happy we get a chance to talk about it. So let's talk about your study design. And this was a retrospective chart review. And we don't often get a chance to review those on this podcast. And this was undertaken for all EMS and ED patients, care records of subjects treated for presumed decompensated CHF with acute pulmonary edema, using a bolus dose of IV nitroglycerin between March 15th, 2018 and March 15th, 2019. Now, a retrospective chart review for those who are on the call and is quite an undertaking. So I'd like to get your thoughts on kind of what was the work effort that went into this, and how did you even begin to look at all these charts?
It was definitely a learning process with a lot of trial and error for us. This was admittedly my first clinical research trial being involved primarily with data collection and study design. So we spent a lot of time talking, really, and drawing and crossing things out and realizing that certain things that worked in my head may not work logistically on the truck, and that was really where some of the paramedic input was invaluable. We knew that this was unique and a unique treatment, so we wanted to collect as much data as we could from the very beginning, but we're limited in that, the more data points you collect, the more chances there are for incomplete numbers. So we really had to fight the urge to try to gather too much. That's probably one of the points where I feel like that we succeeded, in that we didn't try to do too much with what we had. We really wanted to ask three questions. Could the paramedics give the medication accurately? Were there safety issues? And was the medication effective? And with those three questions in mind, that's really the way that we framed the chart review. We wanted to see, what did the blood pressure do when we gave the medication? Did we have hypotensive episodes or other deleterious effects? And once the patients got to the hospital, how many of the patients that we treated ended up truly having decompensated acute pulmonary edema based on ED diagnosis? So that really is the framework for how we went through the chart review. And we used all of our EMS electronic medical records. So we had a system set up whenever a paramedic gave the medication that we got an automatic alert, and that chart was immediately downloaded, reviewed, and filed. And then secondarily, we spent quite a bit of time chasing down the secondary results from the ED data from our various receiving hospitals. And we have 7 main receiving hospitals here in the county. Some of those we have easier access to ED data than others, just based on from a logistical standpoint. So that really was one of the more in-depth and difficult steps, was trying to run all that down, because the hospitals are busy. They don't have someone set to feed that data back to the EMS service. But luckily we have partners that work with us day in, day out, and very collegial. And so we were able to get all that with a little bit of extra work and plug it into the spreadsheet and look and see kind of what happened to these folks. And that was, as that started to form, we were able to see patient 1, patient 2, patient 3. I was more nervous than I expected to be because I just really didn't want to see that 40 over palp and syncopal patient because of the treatment that I brought into the office and decided to push. So as we started to stack the patients up and see that, hey, these folks are doing fine, and some of them aren't requiring non-invasive, and some of them aren't getting intubated, it was definitely an encouraging and positive process.
Yeah, and I think it's great, and I just want to emphasize that you have to have spent, hours upon hours looking at these charts and tracking down the data. It's quite an effort, so I want to commend you for that. It's a lot of work, and I think it paid off in your paper. So let's talk a little bit about, there's a lot of questions now about IRB approval and the difference between doing a research project and a QI project. And you say in your method section that the data review was part of a quality improvement evaluation of the previously implemented protocol. Can you talk a little bit and tell our audience about what your interaction was with the IRB and if it was any different than other pure research projects that you submitted for review through them?
Yeah, I'll tackle this one, Tony. I think the difference is to explain my interpretation, kind of understanding, and I was just listening to a really good session with Dr. Crow and Dr. Wampler about this. So, it is kind of splitting hairs from time to time, but fundamentally, if we had decided to do this as a big quality improvement project, and we have many clinical quality and operational quality improvement projects, and simply this one got IRB approval because it was something that we were already doing. So we implemented this, and as part of our ongoing quality process, one of the things we feel is super important is to go back and look at the data and see, did the intervention that we put in, to whether that be a protocol or a new medication, and to follow that data and then to share that with other people in our, in peer review. Now, the difference between what makes this one easier than I would say a pure research study is this was not something that was experimental. It was not done extensively in the EMS, given this route, but EMS has extensive experience with giving nitrates and IV nitrates and sublingual, different routes of administration very safely. So it wasn't like we were undertaking some intervention that had not been done before. That's kind of how I look at it, between measuring a quality improvement project, which we were going ahead with anyway, whether or not we ever wrote about it, versus starting some new therapy that had less scientific basis and support already in the EMS literature.
Yeah, I'd tag team on there that we've written 4 or 5 more IRBs since this one. The part of it is we are in the great state of Texas and it's delegated practice. So if we want to write the protocol to give 1 milligram of nitroglycerin for acute pulmonary edema, we can do that if we feel like it's in the best interest of our patients, which we did. The key was in writing the IRB paperwork to get approval was to include that sentence that you read, again, that it was a previously implemented protocol. In other words, we were looking backwards at this, something we already decided to do, like Dr. Dickson just said.
And then we very carefully, put the references in there and a discussion of why we felt like that. So we didn't just tell the IRB, we think this is going to work, we're going to give it a go because we can. We put the background. You have to have the background picture in there that's going to convince the IRB that this is an already acceptable therapy modality for EMS.
I agree. I think that's super important, that distinction between what makes it QI and research. You articulated very well. It's working towards a known standard of care. And in this case, the known standard IV bolus is okay. Whereas, sometimes folks use quality improvement or say quality improvement studies won't get published in these peer-reviewed journals, but you all did a fantastic job at being dedicated enough to do the hard work and get this into a manuscript and be able to share it on a national level.
It was definitely a chore at times, so appreciate the kind words very much.
Yes, and one more thing that I really want to highlight out of your methods that I think is important to share with others is how you all went about getting that hospital data. And you created a standardized data collection form, but a lot of times we might think that we need this perfect system and we need this perfect data exchange and all this stuff to take on this kind of project. We can't even start because we don't have the right tools. But can you talk about the simple type of collection form that you use and how you went about getting the data that you needed?
Part of that was we knew that if we submitted a data form with 30 data points, the chances of us getting that back decreased with each added point. So we tried to keep it as simple and straightforward with the hospital as possible. We asked for hospital arrival vitals. We asked for chest x-ray results, lab results if we could get them. We weren't super set on those. Those were really sort of gravy, kind of brownie points, icing on the cake, I guess. And we wanted to know what the final ED diagnosis was from the ED physician, primary and secondary. And we just, through our nurse coordinators and trauma coordinators and stroke coordinators and all the people that we work with, just try to lean on those relationships and be as kind and polite and encouraging as we could possibly be, and let them know we obviously had discussed this protocol with all of our receiving emergency department staff, doc groups, to make sure that everyone knew we were going to be bringing patients in having received this treatment, so that they weren't, freaked out also, nurses and docs alike that weren't aware of this treatment. So we'd already done the preemptive education. So asking for the data really was, we leaned back on that QI portion of it, and, making sure that we want to make sure that our patients are being treated properly. We want to make sure that the medication is being given to the right group and that we're not having any negative outcomes. So when we phrased it like that, we want to follow our patients with our new treatment. It was much easier for us to get those data points.
And to keep the list of asks, we tried to keep the ask very reasonable, and that would be my advice. We only know that because we've gone down the road of asking for too much, and it's really sabotaged some of our projects. And so it's kind of a trial and error. There comes a point where you're asking your hospital partners that it has diminishing return. And so the sweet spot is to try to keep it as short as you can to try and answer the main study objective questions.
Not let perfection be the enemy of good. We really had to fight that urge and just take the obvious answers and try to magnify those.
Absolutely. Avoiding that perfection paralysis and getting just enough data rather than just in case data are definitely hallmarks of quality improvement projects. And I think not being limited by your tool, if you have to document it on a napkin or in an Excel sheet, then so be it, but don't let that be the stopping factor.
Absolutely.
All right, and Dr. Fernandez, do you have more methods that you would like to discuss? I know that these guys are dying to talk about the statistics involved. Or would you like
I'm really excited to talk about the results too. Before we do, I just want to go over one more time your inclusion criteria for our audience. So that you looked at all patients who were given IV bolus nitroglycerin, as well as all patients who presented to the EMS agency with difficulty breathing and the presence of hypertension, which you defined as systolic blood pressure above 160. And this was a free text search that you did in your EPCRs, which again, I commend you for. This is a heck of a lot of work you put into this project. But now I think we have everything we need now that we understand the patients to go ahead and let's talk about some of these methods or some of these results. Excuse me.
All right, Jen, if you can help us go to the next slide. And we do have a question from the audience from Edward. He'd like to know how your field units were carrying the nitroglycerin. So could you talk about what the preparation was?
So we carry the big bottle. It's 100 mics per mil. So the common one that you see in the ED for drip administration. There is a 2 milligram per 5 mil concentration that has existed in the past. At some point, we were unable to source that or find it anywhere. That would have probably been ideal just for a smaller size, but with med shortages being the norm and not the exception anymore, we stuck with the big glass bottle. A little bit of waste, obviously, you're going to use it for a single dose or even a second dose, so 20 mils at the most is going to come out of that bottle, but we were able to source that for under $20 a bottle. So from an affordability standpoint, we felt we were well justified for that price.
I think that's a really important point. All right, now we have another question from Dwayne, but I think we're about to answer it right here with figure 2. Dwayne's asking about how many patients met the criteria for IV bolus after initiation of the protocol, including that administration of sublingual. And so perhaps it would help if we go ahead, either Dr. Patrick or Dr. Dickson, could you walk us through how you identified this initial 250 and worked our way down?
Well, I originally wanted to just look at the group that we treated. I didn't want to look any further than that. But unfortunately, that's not the way this works, and there are other questions, or there are other patients that you missed that could have been treated. That really was the impetus for the initial inclusion criteria of systolic greater than 160 and respiratory distress, which we use surrogate of non-invasive positive pressure as our initial chart review surge criteria. So we took those 250, that was all the patients during that year who were greater than 160 and were put on non-invasive, and we reviewed all those charts and said, which one of these are clearly not acute pulmonary edema? And we were able to pull 162 of those out pretty quickly with another more likely diagnosis, primarily in those patients that was the COPDers with a pressure of 165. And through a 3-person team, we narrowed the 250 down to 88. So there were 88 that we thought, based on chart review, that were likely decompensated CHF with acute pulmonary edema. We had treated 48 of those, so we knew those were hopefully going to be appropriate administrations, and they were after further review based on the paramedics chart. And we look at the other 40 to try to figure out, why did they not get it? Was there something we could do differently from an education standpoint? Was there something that the paramedics were missing specifically? Was there a clinical component? And realistically, 18 of them had no IV access. So we felt like that was a pretty decent reason not to give IV bolus nitroglycerin. While we did allow use in the protocol via IO, no one got the medication via IO during the study period. And then there was a final group of 22 where paramedics deferred IV nitroglycerin. And for the most part, that was really unfamiliarity with the protocol, a general uncomfortableness with the protocol. Looking at those, oftentimes the patients would document considered IV nitrates, and maybe they lacked RALs on exam, for example. That was a common finding that I saw in reviewing the charts. And so we went back to those paramedics individually and said, listen, if the picture has 7 of the 8 pieces of the puzzle, you don't have to have RALs in this situation. Sometimes x-rays, we know from past work and other literature, the x-ray can be clear. So if the patient is tripoding and diaphoretic and has edema and has a pressure of 210 and is on non-invasive positive pressure and doesn't have RALs, don't let that one tiny piece of the puzzle dissuade you. So we took some individual education back to the paramedics from those charts, and that gave us an idea of what the entire population of acute pulmonary edema patients looked like over that year, and then allowed us to concentrate, after answering that question, to concentrate on those who actually got the treatment. I know there was a question I can see on the text string here about sublingual, and again, we encourage sublingual use on that period in between access and patient encounter. So you've encountered the patient, you see them as tripoding, you see them as sick, but you don't have an IV yet. Our medics were encouraged and able to give sublingual nitrates, and a third of the patients in the study group did get sublingual prior to IV access. So to answer that question, I think that was maybe that was Dwayne out there that asked that one. So good question. Thank you.
I agree. And I think that you also bring up an important point. You know, when we introduce a new protocol or a new procedure, it's easy to get the tunnel vision and to abandon what we were doing before. And so in quality improvement terms, that's a balancing measure, is to take a look at, well, are we now giving less sublingual, or are we missing that opportunity to treat early because we're playing with the new protocol versus doing what the standard of care was before? So that's a really good point and really good thing that you measured and reported on. All right, now that we are down to those 48, Jen, if you'll help us go to the next slide, we can take a look at table 1 is traditionally the demographics table. And so we can just take a look at what that population looked like. Walk through, so the median here on age was 72 years. The majority were male and majority white non-Hispanic. And the past medical history is probably important in this one. So 63% had a history of congestive heart failure, and then 77% had that history of hypertension. And is there anything else that you all want to highlight on table 1, or shall we move into table 2 and take a look at some of those treatment characteristics?
Table 1 is fairly self-explanatory. I think you hit those well. We can move on to 2 for sure.
All right, let's go to the next slide. So I'll let you guys talk about this and pick out some of the highlights. I know I see a few, but this table 2, for those who aren't able to see the screen, describes the pre-hospital care that was provided to those 48 patients.
So a couple of the big things here, if you look at our scene times for the service and our transport times, those 19.5 minutes, 18 minutes, those are right at our average scene time, average transport times. So one question that is an obvious one with any new treatment deployment is it going to slow things down? You know, are your paramedics going to be messing around with treatment A or B or C? And in this group, we saw no increase in scene time or in transport time with IV bolus nitro use. So that was encouraging for us. The second thing that I've been asked quite a bit, even since we presented the abstract and since the online abstract went out in the online manuscript, is how you deal with the patients that end up not being acute pulmonary edema, and what happens to those patients, and how do you differentiate? And realistically, the Venn diagram of COPD and CHF, there's a ton of overlap. We know that. So we looked at, for instance, the administration of albuterol, and we found that almost a third of the patients in the study got albuterol. And that was something that gave me a little bit of epigastric pain when we started this. I really wanted to try to specifically target acute pulmonary edema and not have this albuterol overlap. And that was a spot where perfection and the enemy of good, really, I just let it go and said, there's going to be some overlap here. And realistically, in my own practice, I see patients that I give albuterol and IV nitrates to. So I think it's unfair to ask the paramedics with even less clinical information, with less clinical time, to be able to clearly pick one or the other. So we were accepting of the fact that some of these were going to get albuterol, and some of them in the end were even going to be COPD or pneumonia and not acute pulmonary edema with CHF. So that's a number there that was initially troublesome to me, but by the end of the study, we've accepted it, and it's just part of this patient group. The other interesting number to note here that really correlates with Levy's data is that almost 3/4 of the patients in the study only required a single dose, and that reflects directly with their literature, which is really one of the more positive aspects of this treatment, is that you give it once or twice and the patient calm down, and it's very, very much not labor intensive. So that was one of the other, again, encouraging points to me, is that a lot of them didn't even require a second dose. Anything else there you want to pick out, Brinley?
I think you hit a lot of the important points there, and something that you said that I definitely want to emphasize is, hindsight is 20/20. It would be really easy to jump on this and say, well, why did you do this certain treatment, or you missed that overlap. But keeping present what is knowable in the field is really important, and you all did a great job at that.
I guess one final thing before we flip is there were 10% of the patients that were not placed on non-invasive positive pressure. And it was taught very specifically as pair with non-invasive positive pressure. What happened in those patients, looking at the chart specifically, is they got better quickly enough to where they didn't need the mask. So I was initially concerned that we were potentially giving it to patients that may not be sick enough to need the medication. But in reviewing those specific charts very carefully, those patients were hypoxic, tachycardic, hyperdynamic, and calmed so quickly that they didn't need to have the mask. So that was really encouraging. Initially was when I saw the first patient come through that got IV nitro without non-invasive positive pressure, my antenna definitely perked. But looking at the patient's presentation and then looking at the hospital data, looking at the paramedics documentation, it was entirely appropriate for the patient to get the medication, to not get the BiPAP, and they were the diagnosis was confirmed in the ED. So that was a very encouraging part of the paper from an EMS standpoint.
And I think one of the important follow-ups to that is that was Dr. Patrick's and I's clinical practice. We used this therapy, IV therapy, before we implement it in our EMS service, and that's my end of however many patients I've treated with this is I have non-invasive ready, but many of them I never have to deploy it, and the ones I do deploy it, I can take it off pretty short term. I mean, this is a very, very robust therapy for these patients that really are quite dangerous and with their hypoxemia have a high frequency of bad things happen to. A lot of them arrest.
Absolutely. And on that note,
doctors. Oh, sorry. Go ahead.
yeah.
This is Dave, and I apologize for being a bit of a Neanderthal on this topic, but I'm in this is a national podcast, and sometimes the terminology can be a little bit confusing. I heard you say BiPAP and non-invasive, and in some of our worlds, non-invasive positive pressure ventilation could mean BVM versus CPAP. So I was trying to find it in the paper, but I don't see the word CPAP. You're using that non-invasive term as CPAP as well as BiPAP, but not BVM, or was BVM also part of that?
We're lucky enough to have access. We're lucky enough here in our service to have access to CPAP and BiPAP. So apologize for not clarifying there. Realistically, it's whatever your service has, available. There are some folks out there who argue that CPAP may be better for these patients than BiPAP. I don't really want to go down that road and get into those details. But positive pressure in general, when you're going to provide that non-invasive support, whether that's with BiPAP and a PEEP valve, whether that's a CPAP portable mask, or whether that's a full-on bi-level with, a vent setting like we're lucky enough to have here, really any of those, I guess, are what I'm referring to as far as how you would approach this in general. In our service, we're lucky enough to have true BiPAP.
Sure. So it is definitely a continuous or BiPAP type machine. It's not a human hand on a BVM forcing air in, and that's the
not here in FDHC.
Yeah. Okay, got it. Super. Thanks.
That's great. And we have another question from Dwayne, and I think this is worth highlighting, and we are on the right table for it. So he's asking about how many of the 16 that received nitro, or that received the sublingual, also received IVs. So in this table, there were 48 patients who had the IV nitro, and of those 48, also 33% had received the sublingual first. And so could you guys walk us through what the ultimate max dosage would be if they were given the max of sublingual and IV? Did anybody get that? Do you know?
Yeah, I don't know the answer to that question exactly. I know three patients got the max sublingual, which was 2 sublingual or 0.8 is our sublingual max. I don't know if those 3 specifically got 2 milligrams or not, but theoretically in the study, you could get a total of 2.8 milligrams.
All right. And now I do want to move on to table 3. So can we go to the next slide, please? And this is going to show us the difference in some of the outcome measures that we had, which was a change in the vital signs. And I'll let you walk us through, were there any surprises here? Were you pleasantly surprised? Let's talk a little bit about those changes, particularly in systolic and diastolic blood pressure that we saw.
I guess first and foremost, going back to combine table 2 and table 3, this is a super sick cohort of patients. They were very hypertensive, very tachycardic, very hypoxic. Large percentage of these patients ended up intubated either in the EMS setting or in the pre-hospitals, or in the ED setting, excuse me. So just from a 36,000-foot view of this patient cohort, they were really sick. I mean, this is a really hypertensive, tachycardic, hypoxic group of patients. Thinking about this from sort of the textbook management of hypertensive crisis, in our minds, we had hoped to see that 15 to 20%, commonly taught blood pressure management drop in these hypertensive emergency patients, because that's really the group that these fall into. This is a hypertensive crisis. So thankfully, that's really where our numbers fell. We saw really nice decrease in blood pressure, around 35 millimeters of mercury. We saw decrease in heart rate. We saw increase in oxygenation. Now, one of the issues with the oxygenation numbers here, and this is something that we dealt with the reviewers and in our data collection, and this was a spot where good just had to be good enough. We couldn't get perfect, is that there was no standardization of oxygen administration across the patient group. This was at paramedic discretion. So, yeah, their oxygenation improved, whether that was from that, the first reading may have been on 2 liters, the first reading may have been on room air. That was really not an apples to apples comparison. But the reason we reported that was just to show that patients did improve clinically in our care, and they were super sick to start with. Would you agree?
And I think that, we didn't get that granular as to the specific oxygen concentrations when those measurements were taken. But that being said, all of the surrogate markers for severity got better with the therapy. So I think it's definitely trends. I think it correlates with the improvements in the other indices that we looked at, systolic blood pressure and pulse, and some of those other vital signs that we look at to gauge whether a patient's getting better or worse.
Absolutely. And because it just wouldn't be a podcast if I didn't talk about statistics a little bit, and I know Tony's going to smile because we talk about this a lot. I do want to commend your statistics on this and say this table is reporting medians and interquartile ranges, and that's really important. We love to report averages and we love to say the average, but median is actually a more powerful measure, especially when the data are probably not normally distributed. So in this case, there's probably some outliers that would have affected an average. And here, a median tells us so much more. So we can just take the example of the systolic blood pressure, and the median reduction in blood pressure was 33 millimeters of mercury. So that means that 50% of this population saw a reduction that was higher than 33, and 50% saw a reduction that was lower than 33. And then with the added information in parentheses, so that interquartile range was 10 to 55, that 55 is the upper bound, which is the 75th percentile. And that means 75% of this population saw less than 55 reduction, and then 25% saw more than 55. I just love how you chose to display this because it provides so much more information than a simple average and standard deviation would have. So really great job with that.
I guess this is my spot to definitely plug our research partners at NREMT and Ohio State, Rebecca Cash and Panchal. We would have never gotten out of the mud. I did not know what IQR meant when we started this study. So to think that you have to be a stat expert to start these things really isn't true. You just have to have folks around you that are able to educate you and help you out. So these weren't my tables and these weren't my stats. So again, those folks were invaluable if they're listening out there. Thank you for dealing with, speaking of Neanderthal, my Neanderthal stats knowledge. But now I understand why blood pressure is not a normal data set. Really, there's not anybody out there walking around with systolics at 20. So you can't deal with it like normal data, and that's why we went that direction.
Yeah, absolutely. And
That
that's
is refreshing to hear. You know, a lot of medics and pre-hospital providers are thinking, gosh, I'd love to do research, but there's just no way I can get to these, you know, fancy statistical models and tables, et cetera. And it's just refreshing to hear your humility around it and to say, you know, reach out and there will be help. And awesome that you got it from the National Registry, because, you know, a lot of people think that, what's that all about? And the fellowship there, of which we have two fellow graduates here on the call today, but also just the fact that this is kind of the way that we need to destroy the barriers to do research. And I'm just going to say, for the record, for all of you listening, that is what the PCRF tries to do, is to mentor and pair people with those people who can crunch those numbers and help us understand it from an academic point of view and statistical point of view. So great job, and I just really appreciate the humility. So great job.
Thank you. And I would like to go ahead in our last 4 minutes and give us a chance to look at table 4. So if we go to the next slide, this is just some of the hospital data, and I'll ask if there's anything here in the hospital data that you all wanted to make sure to highlight from a clinical standpoint before we go ahead and wrap up and see if there's any last questions.
This really was the answer to the third question that we started with, and that was, can medics target acute pulmonary edema accurately and give the medicine appropriately? And this was, to me, the most important number in the study, really, because this is probably the one I had the most doubt in, and that is how many of these people we give IV nitrates to are going to end up with acute pulmonary edema on an ED diagnosis or a chest x-ray. And 45 of 48 ended up with that final diagnosis. So our medics, just to plug the boots on the ground, and the folks that were really out there treating patients, the guys and the gals, did an absolute amazing job. We've got great paramedics here at MCHD. I couldn't be more lucky to have a team like we have. The 250 to 300 that we get to work with every day are really a joy. And to see this number, you know, as someone who came up with an idea and decided, can we do this? And then to see the paramedics take it and run and give it to the right patients, pretty darn amazing. The other three, if you're asking the question, which we did, what were the other three? 2 were COPD and 1 was pneumonia. Both were hypertensive, tachycardic, hypoxic. Paramedics documented things like RALs and edema and CHF history on those 3 patients. So they were very appropriate from a protocol inclusion standpoint. It was really inarguable that it was appropriate patient to get IV nitrates, but after more information collection, they ended up not being acute pulmonary edema. The other good part of that sliver of 3 is that none of those 3 had any adverse outcomes en route or in the ED. So if you're worried out there and you want to implement this, just know you're not going to hit 100%. You're going to have some that get IV nitrates that don't have acute pulmonary edema, and that's okay. Those patients in our study, in the older French and Israeli studies, in the Levy studies, those patients did okay as well. So you don't have to be perfect with this treatment, and there's going to be some overlap. So that would be my main point. Some of the other hospital data was admittedly a little lacking. This is where we want to encourage folks out there that have a little more resources and a little more research support. This is, you know, we tried to lay a little bit of groundwork, and hopefully somebody can take this idea and run and really look at morbidity and mortality, intubation rates, admission rates, and piggyback on this and use it for their RV submission and collect more data here and spread this treatment and spread the research.
Oh, I love those words, and I couldn't agree more. And I think it is the right moment to plug not just one, but several ESO workshops that the PCRF is doing with ESO. And I know Remley would and Tony would not be able to do this because of any conflicts, but I certainly can say that ESO has been such a great partner to find and be able to use data sets that are connected to electronic health records. And I was worried about the exposure, the number of patients who qualify for this. But if we were to take one of those workshops and be able to crunch some numbers around what is the frequency of this acuity, this kind of patient, so we get a better idea of a exposure to this particular problem and our ability to help medics recognize this. So I really, again, want to just applaud you. Great job.
Thank you. Just really quick, wrapping up, there's one more question and one more thing that I have to say so I don't get in trouble. Edward asked about the ceiling for sublingual nitro, and it was always 0.8. We didn't change that protocol in relation to this study. So that the sublingual dosing and amount stayed the same before and after. Secondly, we talked a little bit about our IRB maneuvering, and just to hit on Kelly Rogers Keene at Baylor, she has put up with our inadequate IRB submissions over and over for the past few years and was able to get this one cleared for us. So we wouldn't be talking to you without her either. Elizabeth Adams also was a med student who worked with us and who did a ton of bibliography research and background research. So the biblio would have been probably a lot thinner if it had been up to just me. So I'd like to thank those folks also.
I think that's wonderful. And this is a wonderful example of a team coming together and bringing in the pre-hospital providers to make research possible and to disseminate this work. And this is important pilot work for what we hope there will be more future studies. And so, again, to sort of remove some of my conflict with the research forum that Dave mentioned, anyone and everyone is welcome. You don't have to be an ESO customer, so you can sign up at eso.com/research-forum. We hope that lots of folks will come join us and ask some of these important questions and see perhaps if this study is being replicated. Others are using similar protocols, so would love to dive some more into the data. And again, I want to thank the authors for sharing their time with us and sharing what they've learned, particularly about this study. And so just thank you again, Dr. Dickson and Dr. Casey, for being here with us. Dr. Patrick.
Thank you. Thank you for having us. I get called Dr. Casey once a day at least, so no problem there. I go either way. Thank y'all for having us. Thank you for highlighting our research. We're proud. We're lucky to be part of the service. Again, thank the board and the administration and all the support that we have to do projects like this. I agree with Dr. Dickson. We are very lucky medical directors. So thank you all.
Thanks for having us on, guys.
Yes, thank you. And please don't hesitate to reach out to the authors or us with further questions. I see there's a couple more coming in, but we do have to wrap up. So I'll go ahead and move us to our last slide and remind you all to join us for the Education Research Podcast that happens later this month on Friday, February 28th at noon Central. And we will be back here next month with our clinical podcast on the second Monday, which will be March 9th. And thank you all for listening. Look forward to being here with you again next time.